Welcome to IPOPI webinar. Thank you all for taking part in this session. I am Martine Terjean, the president of IPOPI, and this is my pleasure to moderate this webinar. This webinar has been made possible thanks to a donation from Takeda, who we sincerely thank. Today, we will learn about the importance of patient-centered immunoglobulin therapy. We all know that this lifelong treatment is vital for patients with primary immunodeficiency who have no other therapeutic option. We also know that this biological medicine exists in different forms and can be administered in different ways. That's what interests us today. To address this topic, we have a great specialist with us, Professor Torgerson, from University of Washington and Seattle Children's Hospital, USA. Professor Torgerson will, for concrete situations, demonstrate that there is certainly an approach more suitable than another to an individual situation. An approach that illustrates the patient-centered concept. We are honored to hear his lecture today. So, how will this webinar work? Professor Torgerson will soon begin his presentation. During the talk, you will be able to send written questions in the tab that you see on the right side of your webinar screen. After the presentation, we will discuss some of your questions with Professor Torgerson, and Dr. Nisa Malawi from Necker Hospital, Paris, is also here today. You can see both of them on the top, on the bottom of your screen, to answer some of your questions in written, and for that, we can thank you to Dr. Malawi. Professor Torgerson, the floor is yours.
Thank you. It's really a great privilege to be here, and thank you for inviting me to do that, to be here. And good morning from Seattle. It's early in the morning here, and I'm glad to be on. I am excited to talk today about the use of immunoglobulin in patients, and really talking about aligning the treatment approach with what patients need. And I'm going to do that through a series of cases, and this is the outline of what I'm going to be talking about today. So I'm going to give a little bit of background, and that background, I'll tell you a little bit about the area of the world where I practice and where I have the opportunity to see and treat patients, because that provides a little bit about why we have to make these adjustments. And we all practice in situations where we need to adjust to meet patient needs. I'm going to talk about the available routes of immunoglobulin replacement therapy. I'm going to really do this talk through a number of patient vignettes, and then a brief summary at the end. And so that's the outline of what I'm going to try and cover today. So just to give you a little bit of background about where I have the privilege to see patients, I work here in Seattle, which is in the state of Washington, in the Pacific Northwest of the United States. And that's the area that's in bright green there. The red star is where Seattle is. And we cover patients across this large 6-state region. And I've put to the side, just to illustrate sort of one of the challenges that we face here, which is that there's a lot of open space in the Northwest United States, in the Pacific Northwest. And so it's not tremendously populous compared to a lot of other places in the world. And so people are really spread out. And especially in some states like Alaska, where patients are very spread out and sometimes living in very remote locations, which add to the complexity of how we treat patients and how we sort of work with them to organize their care around using immunoglobulin replacement therapy. You can see there that within the Pacific Northwest, there's 0.2 square kilometers for every man, woman, and child who lives in the Pacific Northwest. So we are kind of spread out. So this is where I practice, and what you'll see some of this coming out as I talk about these patient vignettes. So just to review quickly the different types of immunoglobulin replacement products that we have available to us, and of course there's the standard intravenous products that are 5 to 10% typically in concentration. Some of them are pre-mixed liquids, some of them are lyophilized and have to be mixed. They're in a variety of carriers. Of course, classically, some of these carriers were sugars, maltose and other things, but some of the newer preparations have carriers that are amino acids like glycine or proline, for instance. There's the subcutaneous products, and the subcutaneous products are 10 to 20% in concentration typically. They are again in a variety of carriers and administered to be administered subcutaneously. Then there's one facilitated subcutaneous product that we have available, in which it's a 10% product, but it's given in with a method that's an old method actually for giving rehydration fluids called clysis or hypodermoclysis, where you pre-administer a dose of hyaluronidase subcutaneously to sort of loosen up the subcutaneous tissue a little bit, so that you can actually infuse a large volume. And so we have one facilitated subcutaneous product available to us now, and then of course there's the old-fashioned intramuscular product that's been around for a long time. The one that we have available here in the U.S. is a 16% product. We don't use this very often. Again, it's a painful way to receive immunoglobulin replacement therapy, so I'm not going to address that one much, but I will be talking about these other approaches to giving immunoglobulin replacement and how you use those. I think the bottom line is that there have been a number of studies, sort of some comparing one against another, and it seems like all of the products, no matter whether they're delivered intravenously or subcutaneously, are all efficacious at preventing infections. And so really the most important reason that we have these available is to make it possible for us to treat patients in a way that is convenient for their lifestyle, and that makes it possible for them to have the least possible impact of their disease on their quality of life and on their lifestyle. And that will hopefully emerge as a theme as we go through these cases. So each of these cases are real cases, cases that I have seen in my clinic, and that each illustrate a specific point. So let's move on with the cases here in a moment. First of all, I just wanted to remind you about the pharmacokinetics of how these immunoglobulin replacement products are administered. Remember that with IVIG, of course, there's a huge initial spike in the serum levels of IgG when you give IVIG, that then drops off fairly quickly, and then more slowly over the course of the month until you get back to baseline. And that's shown in red. And then, of course, in blue is the weekly subcutaneous immunoglobulin, where it's much more of a steady state. Some fluctuations, but over time, the level of immunoglobulin in circulation is very steady. And then in green is the pharmacokinetics of the facilitated subcutaneous products, where you're giving a dose of hyaluronidase, then you're giving an entire month's worth of IgG subcutaneously. Because it's given subcutaneously, you don't get the huge initial spike in serum levels, and it's a little bit more level over the course of the month. So this is just to remind you of what the pharmacokinetics of each of these approaches of delivering immunoglobulin replacement looks like. All right, now let's start with the patient vignettes, and hopefully you'll recognize in these patients some of your own patients, and may think about ways that you can adjust therapy for each of them. All right, so patient number one is a gentleman who was diagnosed with CVID almost 30 years ago. He's a 62-year-old construction worker, and he lives, as seen on the map, he lives in the central part of Washington State, there where the blue star is. It's a rural area. He lives out there, and his full-time job is as a construction worker. We are located at the Red Star in Seattle, and so he comes over to see us once per year for his clinic visit. He was diagnosed, like I said, about 30 years ago with CVID. And so far, he's only had infections. He's not had other complications that we sometimes see in CVID. He is an avid dirt bike rider, as you see on the right there. That's not his picture, but that's what he looks like when he's out riding. And he's a motocross racer, and so he likes to do that on the weekends. And so for him, it was really important that he's a very active guy. He's likes doing things on the weekends. He lives in a rural area. He's not near an infusion center. And so for him, he wanted simplicity, is what he told us. He wanted it to be simple. He just wants to get his infusions done, and he doesn't want to think about it for the rest of the month. And so he was actually, years ago, one of my colleagues, Hans Ochs, actually taught this gentleman how to place his own IVs. And so the company just delivers the supplies to him. He places his own IVs, and he's got a TV program that he watches once a month, and he places his IV and then watches a TV show while he infuses, and it really is a minimal impact on his life, and it's allowed him to continue his lifestyle to be very active. And so for him, he gets a 10% product, gets an IV, he places his own IVs, and doesn't even need to have home health come into the home to do that. And so for him, this was the right choice. Now, he's a construction worker. He's got really nice veins. It's easy for him to access those and place his own IVs. And so for him, this approach worked out well. Patient number 2 is a 52-year-old commercial airline pilot who flies for one of the local commercial airlines. The route that he's currently flying, he's actually based mostly out of Anchorage, Alaska, but he lives in Seattle, and so he flies the route from Anchorage to Hawaii back and forth. He was diagnosed with CVID about 3 years ago. So far, he has only had infections as well. He's not had other complications. So what was important for him? Well, so he's required to travel frequently with his job. And so, and of course, in the process of that, he needs to pass through security frequently, and his work schedule can change with very little notice. And so, having to schedule a time in an infusion center where he would have to go in at a particular time would be very complicated for him. So for him, he really needs convenience, he needs flexibility, and he needs an ability to travel easily with his product if he's going to be away for a while. So something that doesn't have to be refrigerated. And so for him, as we look through the options, we thought the best solution for him was a subcutaneous product that doesn't have to be refrigerated, comes available in small vials so that he can pack those in his luggage, and he can take those with him, can pass through security with those, not a large volume in any one of those. And so that has worked well for him. And he has done very well with this approach to treatment with immunoglobulin replacement. All right, patient number 3. Patient number 3 is a 2-year-old boy with IPEX syndrome who had a bone marrow transplant. And so he's on immunoglobulin replacement because of his bone marrow transplant. He's from Alaska, and you see there the map of Alaska, and overlaying the map of Alaska on the map of the United States, just to give you perspective for how much space there is in Alaska. It's really a large state, and he lives in a rural area outside of Anchorage, Alaska. He's a native Alaskan boy. He was diagnosed with IPEX at a year of age, underwent bone marrow transplant, and was sent back to his village in Alaska. But there's some difficulties with compliance for him, and those difficulties really arise because he lives in this remote village. The only sort of trained health worker in his village is a health aide who has really minimal training. Is not able to do any significant procedures. There is a general pediatrician in a nearby town, but there have been some challenges with compliance for this patient, and with the patient getting all of his medications in a timely fashion. And he's got graft versus host disease. So we decided that what he needed was, we really needed to be absolutely certain, because he'd recently had a transplant, we need to be absolutely certain that he was receiving his immunoglobulin replacement. And so we also needed opportunities to evaluate him regularly because he'd recently had his BMT and he had some ongoing graft versus host disease. So we decided that really the best approach for this patient would be to have them travel into Anchorage once per month to see a hematologist oncologist in Anchorage who could evaluate his graft versus host disease. While he was there, they could also administer the immunoglobulin replacement as a 10% IVIG product. So we knew that the immunoglobulin had gone in. We knew that he was protected from infections since he lives in this remote village and was exposed to all sorts of things. So for him, that seemed like the best approach to assure that, in fact, he got his therapy and that he was able to be assessed on a regular basis. All right, let's move on to patient number 4. Patient number 4 is a teenage patient that I see who lives in Pendleton, Oregon, which is where the blue star is there. And of course, again, Seattle is the red star in the state of Washington. He's a 16-year-old patient with common variable immunodeficiency, and he's got non-malignant lymphoproliferation. So he's got pulmonary lymphoproliferation, large spleen, large lymph nodes. He was diagnosed with CVID at the age of 11. And as I said, he's got massive splenomegaly and diffuse lymphadenopathy. He'd been doing weekly subcutaneous immunoglobulin, and that had worked out reasonably well for him for the first few years he was being treated. But as he's gotten older, he's developed increasing anxiety associated with his infusions. And this has created some real problems for him because each week, as he gets, his mom actually is the one who administers the infusions, and as he gets ready to get these, he'll start to get anxious the day before the infusions, just thinking forward to this, and so it's created a significant problem just with his quality of life, and so one day a week he's just really anxious and wound up. And so he's developed this increasing needle phobia. And so we needed another approach. He didn't really want to go into an infusion center because that would have meant that he would have probably needed to have missed at least one day of school per month. And so we needed another approach. And so his challenges were that he had increasing anxiety with infusions due to needle phobia. He's had bad experiences with IV placements by home health in the past, so that wasn't going to work. And he doesn't really live near an infusion center, so he was going to have to travel a ways. And so ideally, he needed something that he could self-administer, minimal number of infusions per month, and ideally no IV placement. And so the solution for him was to use the facilitated subcutaneous product that I mentioned previously, where he receives a dose of hyaluronidase followed by his entire month's dose of immunoglobulin replacement, so which is about 300 milliliters of immunoglobulin that he receives subcutaneously, and that has worked very well for him. It only requires one needle poke per month. He receives his infusions in the subcutaneous tissue over his abdomen, and he's done very well with this and has been able to remain compliant and not be as anxious. All right, let's move on to patient number 5, who is a 65-year-old female with common variable immunodeficiency and poorly controlled rheumatoid arthritis. So this is a woman who was diagnosed with CVID about 10 years ago. She developed rheumatoid arthritis and other autoimmunity about 6 years ago, and it's really created a lot of challenges for her. She's had multiple reactions to medications as this has gone on, and of course she's been exposed to a lot of medicines because of her rheumatoid arthritis. So her challenges were that because of her rheumatoid arthritis, she has a real challenge with manipulating needles and doing self-infusions. So those really were not options for her, either subcutaneous or placing her own IVs. And she's had a lot of severe medication reactions. So she needed help with infusions. The infusions need to be performed in a safe environment where she can be monitored since she's had infusion reactions. And so for her, it made sense to have her receive her product, her immunoglobulin replacement, about every 3 weeks in a hospital-based infusion center where she could be monitored for infusion reactions, anaphylaxis, and she could receive pre-medication with Tylenol, Benadryl, and steroids. And so for her, that made the most sense, and that's what she's continued to do. And then patient number 6 is a 16-year-old female who's in the ICU. You get a call about her. She's got pneumonia. This patient happened to live in Montana, there in the red state. She had a history of recurrent infections, but now was admitted to the intensive care unit with a lobar pneumonia. And the local physicians, in doing her workup, had noted that she had significant hypogammaglobulinemia. So what did this patient need? Well, she's acutely ill, and when she's discharged from the hospital, she's going to return to a relatively rural area near Billings, Montana. She needs protection now because she's acutely ill. She's in the ICU. She needs immunoglobulin quickly. And so, and then following that, she needs the ability to probably infuse at home since she lives in a relatively low area. So what's the approach that you take in a patient like this? Well, for us, we said, gosh, she needs to be loaded with IVIG while she's there in the hospital, get her levels up quickly to try and assist in clearing this acute infection. And then once her levels, her plasma IgG levels are in the therapeutic range, she could be transitioned then to a subcutaneous product for home infusion once her levels are at a normal in the normal therapeutic range already. And so this was the approach that we took with this patient. And then the last patient that we have is a little guy. He's a 4-month-old boy with neutropenia, and he was being treated for neutropenia. But then was also found to have low IgG, IgM, IgA at around 4 months of age, and was diagnosed with X-linked agammaglobulinemia once his mother's immunoglobulin had sort of dissipated, and had neutropenia associated with his XLA. Now, what were his challenges? Well, like the picture, he was a very chubby, well-nourished baby, and it was difficult to get an IV in this little guy. He was a difficult IV placement. He was very active. Once the lines were placed, he would play with and tug at the lines, and he'd grab the lines and suck on them. And so this was the challenge with him. Ideally, something that he could get without having to have an IV placement would be the ideal thing. So and then something that would be kind of brief and they could administer quickly. So what was the solution for this patient? Well, we decided that maybe the best approach for him that would not require an IV placement would be to use a subcutaneous product that could be administered by his parents once every other day by push. And so what his parents do is they place the needle with an infusion set, and they actually just hand push. They don't use a pump. They just hand push just a couple of milliliters of immunoglobulin subcutaneously for him at a time every couple of days. And that has worked very well for him. And they did this actually for about a year until he got a little bit older, at which time they then transitioned to a more traditional subcutaneous approach using a pump and delivering a little bit more volume once per week. But for them, this approach of being able to deliver just a little bit every other day worked very nicely. And it was quick. Just took a few minutes for them to hand push the IG in, and that worked very well. And then lastly, just to summarize, I wanted to just summarize the factors then that affect the choice of IgG replacement, IVIG versus subcutaneous IG, and then of course the facilitated IG. Remember that the pharmacokinetics, there's a wide, with IVIG, of course, there's a wide range because you get the big spike and then the taper off over the course of the month. Whereas with traditional subcutaneous, it's a more constant level. Systemic side effects are common with IgG, much less common with subcutaneous. And so patients who are having a lot of systemic side effects, subcutaneous can often be used to ameliorate those. Infusion site reactions are infrequent with IVIG because, of course, it's being delivered into the vein, but more common with subcutaneous. And that's something that you need to pay attention to in using subcutaneous infusions. The site of infusion or the location of the infusion, of course, the IVIG needs to be given at least in an infusion center or in the home, often with the help of a home healthcare nurse, or sometimes patients can be taught to do that themselves. Whereas with a subcutaneous IG, it can be given anywhere. And patient satisfaction is, some patients who are needle phobic, they like to just get one poke a month get it over with. That can be advantage with this IVIG or facilitated subcutaneous, and whereas with the subcutaneous, it's very flexible, can deliver that little impact on quality of life in many cases. And lastly, for compliance, for treatment compliance issues, IVIG given an infusion center is really great because you can monitor, make sure that the IgG actually gets into the patient and that they are protected. So that's what I wanted to present today. Hopefully that gives you some ideas for how you might treat your own patients and tailor therapy for them. And I will stop there and be happy to take any questions. Thank you very much.
Thank you, Professor Torgerson, for this great presentation. It was very interesting to listen to. To follow up on this, we will turn our attention to some questions of the audience. And with that said, I would like to welcome Dr. Nizar Malawi on stage. Nizar Malawi, do you hear us? Yes?
Yeah.
And I can see that you already have answered many questions because we got many. Mostly physician, but I can say that the audience is not only physician, but also many patients or patient representatives. Well, we have very diverse questions. For example, I have one here. If I am infusing myself at home, how can I know that I do well? I do it correctly. It's a joke. I'm sorry, but
Well, so I think, if it's IV infusion at home, if you're doing that, if the IV is not placed appropriately, it becomes quite painful, and you'd obviously see the fluid leaking into the tissues, and so you would know if that was not infused appropriately. For subcutaneous infusions, in all honesty, it's very hard to do that incorrectly. The way that the needle sets and everything are set up, it's really made it almost foolproof for the administration. And the other thing, of course, is that you can monitor blood levels of IgG, and if those are in the range where they should be, then it's obviously getting to where it needs to be. So
okay.
I think that's the way.
Thank you so much.
And the other thing I would add one more thing, which is if you're giving subcutaneous and it's very painful or you're getting a lot of bruising, that may mean that in fact it's not going into the right place. That is one situation where sometimes you need to have somebody look at that and sort of help you. Might need a different length of a needle or a different infusion rate, or some things can be adjusted there if it really is very painful to do the infusions or you're getting a lot of bruising.
Okay. There is a case from physician, I'm just looking at it. Yes. How do you decide IVIG dose for obese patients? And the precision is my patient is BMI 32.
Yeah, boy, this is an ongoing challenge, and it's really a challenge actually right now because of the IVIG shortage that we're experiencing. And I don't know whether you're experiencing this in other parts of the world, but here in the United States, we are in the midst of an IVIG shortage, and it's a real problem. And so this question becomes very relevant because are you going to dose based on actual weight or on ideal body weight? And there's different theories about this, and I would say there's really not agreement. What we've gone to in the midst of the shortage is to dosing by ideal body weight because we don't have enough to go around. We're trying to stretch it to meet everybody. And I think the most important thing is how the patient is doing. And I think you treat to effect, to biological effect. If you're treating based on ideal body weight, the patient's still getting recurrent infections, then obviously I think they're probably not getting enough, and you need to give more and maybe even up to the dosing it based on their body weight. I think you can start with ideal body weight, but then then treat to biologic effect, which is to prevent infections.
Yeah. And Dr. Malawi, I could see in some of your answers that clinics is very important because you got some answers on that.
Yes, I totally echo Troy's answer. The trough level is obviously very important, but we need to carefully monitor the clinical status. And if the trough level is okay or even good, but the patient is not doing good, not enough, then we want to increase the dose of IV or sub-Q.
Okay, Professor Torgerson, you You mentioned the tensions in immunoglobulins, and we got some question. For example, one here in my country is not a matter of choice, but of availability of IGs. And every time I go to a hospital, every 3 weeks, I get a different IG. And it is very hard to assess the side effects. How can I be sure that they are related to one product and not to the other? One tricky question again.
Yeah, boy, that's a really tough question, and I think well, it's a tough situation. I think we know that that with every switch of product, there's data to show that that's when we often there's a higher incidence of reactions of infusion reactions with product switches, and so that's a very difficult situation. The only recommendation I would have to try and link side effects with particular product is to keep good records. So in the research lab, we have lab notebooks, and we keep very careful records about every part of an experiment. And I would view this as sort of an experiment. You're being you're trying different products, and so what I would do is get yourself a notebook and write down what product you're getting and the infusion rate and all of the things about that particular infusion. And if they'll give you the sticker off of the bag or off of the box that you can stick there in your notebook so that you've got that information, and then record what sorts of infusion reactions you have after that particular infusion, because the patterns will begin to emerge if you keep records. But I actually think that that's probably the best way to try and link side effects to particular products.
Yeah, thank you so much. I take the opportunity to mention that we have PID Genius, an app to help you to track your treatment. Another case, my daughter is subcutaneous with the Cuvitru, abrupt, but very tired before and after treatment all the time. Does it mean that the treatment is not right for her? So the fatigue, which is an issue that often,
Yeah, it's a good question. It's an ongoing challenge. Oftentimes we see patients who become fatigued or tired before their next dose of immunoglobulin. Sometimes that means that maybe they need a little bit more to bridge them across that, so that they don't get fatigued at the it's been described as the wear off effect or the tail off effect, people have called it. We see it more in the IV infusion setting where there's a drop to a real trough, less in the subcutaneous. And then, of course, after the infusion, there can be side effects related to the infusion, which can cause fatigue and headaches and other things. And it gets very difficult to tease that out. And so, I think, again, if you have options for maybe trying a brand switch, trying a switch to a product that maybe has a different carrier in it, or other things, you might try that and see whether that makes a difference for the infusions. And if you're getting very fatigued right before your infusion, you might try even a slightly higher dose to see if that would bridge you across to the next infusion.
Mm-hmm. Again, another situation with the winter holidays approaching, my daughter will like to go on a sky camp for 3 weeks, but she's under subcutaneous, and how can she deal with that?
Well, again, getting back to the airline pilot that I talked about, if you're on subcutaneous, and it's most of the subcutaneous products I don't think need to be refrigerated now. So depending on where you're going, depending on how much volume and how much weight that, if you're hiking or what, take it with you. You can infuse anywhere. I mean, the other thing, if you're going for 3 weeks, you can sort of bulk up, sort of stack them up right before you go, and stack them up again right when you get back. And you could, in theory, you could miss the 3 weeks if you stack up before and after. It's not ideal. If you could take at least one dose and administer sort of midway through the trip, that would be ideal. But, that's the beautiful thing about subcutaneous, is that as long as you get that month's worth of IgG in your body at some point during that month, you're probably mostly protected. It's not ideal, but it's works pretty well even that way. I have patients who do that. So
yeah, maybe Dr. Malawi, I know that in countries, especially ours, that some patients or some physicians put their patient under IVIG for one time or two, especially during the holidays?
I totally agree with that, Troy. It really depends on where the trip and how, what are the conditions of the trip. Ideally, not interrupting the treatment would be best. But for some patients, when it's like basically very difficult to stack up and bring the treatment with them, what we have experienced with successfully with many patients is to provide them with one course of IVIG a few days before their holidays, and then when they come back, they can go back on their regular treatment of sub-Q.
Mm-hmm. Thank you very much. I think we will move to last questions because it's seasonal, at least in the North Hemisphere. It's just about vaccination. Somebody asks if I have immunoglobulins, do I need to vaccine?
That's a good question. So for most vaccines, no, you don't need them. However, there are some exceptions that at least that we consider exceptions, and I'll be interested to hear if Nizar agrees. So we do suggest that patients get the influenza vaccine each year, and the reason for that again is that the way that the immune system tackles viruses, it uses antibodies, which are in immunoglobulin replacement, of course. We'll get back to that in a minute for influenza, but it also uses T cells, and so the vaccine presumably sort of helps to train both arms of your immune system, and so we are trying to train the T cells, number one. So that's number one. The other issue related to influenza is that again, because the virus changes every year, and it takes about 18 months to produce an IG product, really the antibodies that are in the IG products that you're using right now were really binding to the influenza that we had 2 years ago and not this year's influenza. So it's a way to sort of try and provide some extra protection against maybe this year's influenza strain as well, because those antibodies may not be in the current lot of IgG that you are receiving. So that's one vaccine that we recommend. The second vaccine that we actually recommend in older patients is we recommend the new shingles vaccine, which in the States is called Shingrix. It's the killed shingles vaccine. There's a live attenuated vaccine and a killed vaccine. Again, we do that. There's plenty of antibody to varicella virus in the IgG, but what we're trying to do is train the T cells really to give better T cell responses to try and keep that varicella virus in check so that you don't get shingles. So it's recommended in everybody over the age of 60 here in the States. It's recommended that they get a booster, but we now that there's a killed version available, we're recommending that to our patients as well.
Okay.
Those are the two kind of exceptions that we consider in our clinic. I don't know if Nizar is different, but
oh no, I totally agree with you, Troy. It's a very important question. I think we would also recommend to the families that all family members should receive immunizations in order to prevent the circulation of the bugs to the patient himself or herself. And also, in case of traveling abroad, some immunizations might be required by authorities, or because of the endemic presence of any specific bug. But I would definitely recommend to really get in touch with your specialist, the PID specialist, and to do so ideally many months in advance.
Yeah. Okay. Thank you very much, both of you. Now we come to the end of this webinar, And on behalf of IPOPI, I would like to say a big thank you to Professor Torgerson for your very interesting talk, especially so early in the morning, and all the answers you provided. We also thank Dr. Malawi for answering some of the questions, especially in written, because Troy, you don't know, but he did a lot of work. And thank you to all of you for attending this IPOPI webinar. Please note that you will be able to see the recording on IPOPI TV within a couple of days, and don't hesitate to share it as much as you can. Many thanks again to Professor Torgerson, Dr. Malawi, and to Takeda, and we hope to see you soon in an upcoming IPOPI webinar. Bye.